going.
Perfect. Okay. Well, good afternoon, everybody, and thank you very much for taking time out of your day for the presentation. It's always exciting to chat about this, and I made this unique to really talk about kind of to make sure that we move on this presentation. So,
sorry, forgot about my sound.
Myself.
Sorry about that.
No worries. Okay. So I hope to share with you a little bit about the thinking around the senior strategy that I've been privileged to work on over the last year, and kind of just tell you about a little bit about what I observed personally, and where I think we need to go as a province, and how this kind of influences. I understand that we have some people from Dalhousie and some other areas, so it'll be interesting to kind of share some of the things we did, because as we started developing our work, we wanted to certainly not only look at what's best practice in Ontario or in our city and our communities, but also look at other regions across the country and around the world to see if we could learn from some examples there. So I look forward to sharing some ideas, and we have time for a lot of discussion as well. So the presentation objectives today are really to kind of start highlighting some of the disconnects that currently exist in our health, social, and community care systems as it relates to the way we interact and work with older Ontarians in particular. And I want to demonstrate how some of our communities and care delivery paradigms can adopt a more elder-friendly approach. And then I want to provide some of the context and early observations related to the development of a senior strategy for Ontario. So in terms of our context, these are some of the numbers. Really, 14.6% of Canadians and actually Ontarians are 65 and older, and yet they account for nearly half of our health and social care spending. And that's just the reality. As we get older, we start having more health and social care issues and needs. And so that's just naturally where the bulk of our healthcare spending is accounted for. It's with a small percentage of the population. And this is the challenge, as the Minister of Health always says, and she actually has a PhD in demography, she always reminds everyone that not only do we have a fiscal challenge right now with an $11.9 billion deficit, but we also have a demographic imperative on our hands. Because as we know, as the boomers have started just turning 65 a few years ago, their population is going to double. The 65 and older population will double in the next 20 years, while the 85 and older population is set to quadruple over the same period of time. So if you're a believer in apocalyptic demography, you can say, well, the elderly will bankrupt Canada and this is the end of it. But we can look at this as an absolute challenge, or we can actually look at this as an opportunity. Because a line that I always like to use is, the patients have changed and the system hasn't. And we have to remember that, only 100 years ago in 1900, the life expectancy of a Canadian, does anybody know what that was? 51 years of age, absolutely, right? So someone's reading their reports from Stats Canada. But 51 years of age. But our life expectancy now, anybody want to guess? People know what that is around.
71, 72?
High 70s for men and early 80s for women, right? So the idea is, we have more people living longer than ever before, and we should celebrate that. I think that's the greatest accomplishment of the 20th century, is that we almost doubled our life expectancy. But we're living in a world where there's a great stat. If you travel as much as I do, you read all those HSBC ads that they have in the airport as you're getting on and off your planes. And one of the latest ads they actually have is this wonderful kind of way to conceptualize it. They say 2/3 of the people in the world who've ever lived beyond 65 are alive today. Which is, when you think about it, right, we have a whole new part of our society and more of those people than we've ever had before. So again, how does our world start reflecting a very different population in front of us? So for those of you who are not so healthcare oriented, we have our regional health network system called LHINs, or Local Health Integration Networks. So there are 14 of these across the province, and you are actually physically sitting, those who are in this room, in the Toronto Central LHIN. And so these are the numbers when it looks at aging and hospital utilization, because we're going to have a bit of a healthcare focus to this talk in particular. And as you can see by the numbers here, when you actually, so I'm going to use this cursor so that everyone can see. I think the people who are watching can see this on the computer as well. Perfect. Okay. So when you're looking at the, where did my cursor go? Oh, there it is. Okay, let's not lose it now. So when we actually look at those, so again, Toronto Central, we have a lot of younger people living right here in downtown Toronto. So 14% of the population is 65 and older, yet this older population represents 21% of the emergency room visits, 37% of the inpatient admissions to hospital, 75% of the rehabilitation hospital admissions. And we always have this curious term in Canada now, a much more polite term than the more derogatory term of bed blocker. We have the politer term called ALC, alternate level of care. So that's the term we say that when we have a person who's finished their acute care and now they're waiting for home care or waiting for a long-term care, a home placement, for example, they may be waiting for days or sometimes even months in a hospital, and we designate them ALC. So 83% of the people who are ALC in Ontario or in Toronto Central LHIN are actually are people who are 65 and older. But we also see that not all of the elderly are the same, right? So when we think about the 65 and older population, this last column over here shows what the utilization is of those the percentage of the older population that's 75 and above. And you can see again the majority of usage within the older population are in those adults who are 75 and older in particular. So this is actually the data from Erie St. Clair LHIN. This is actually the Sarnia, Windsor area, so in the bottom kind of left-hand corner of Ontario. And the reason I show this data is because when I actually was going around Ontario last year to each of the LHINs, what I was ready for people to start saying is, well, Dr. Sinha, you live and work in downtown Toronto, and downtown Toronto's issues are not necessarily the issues of Erie St. Clair LHIN or the Northeast LHIN or anything. So luckily when I went around the province, I actually had a slide like this made up for every region I was in, and people started saying, well, wait a minute, what are you saying? It's the same,
Exactly.
right? It's exactly the same. It feels like, well, actually we have 2% more, and forget it, right? The overall concept is nobody actually ever dared say that, right? I think people got the point where, yes, there are regional differences in our province, and there are issues with, please come on in, there are regional issues in the province, and yes, please come on in. Yeah, no worries. So there are regional issues in the province, like in the northeast part of Ontario, for example. 25% of the population are Francophone speaking. We have our largest populations of Aboriginal peoples in the northern parts of the province. So there are unique health issues and needs. There are 170 languages spoken in Toronto Central, for example. So we have to think about all those things, but there are some commonalities in our healthcare usage and utilization. And so there are some common issues that really start making us think of why we actually need a provincial strategy when there's so many common things that actually unite us as Ontarians, more than we sometimes would like to think. So this is actually the data, again, as you walk it up to all of Ontario. Again, 14.6% of the population accounts for 39% of inpatient visits to our hospitals. And because older people tend to stay longer in hospital, they account for 60% of our actual bed days in hospital. So when I was actually a medical resident, when I did my medical training in Toronto, and I'd be in the hospital wards, 60% of the patients on my actual list were older adults. So you have to imagine that as a young intern, I naturally started to believe that when you retire in Ontario, you actually sell your house and you go live in a hospital, because it just seemed that all of our hospital beds are just filled with older people, and when one leaves, another one just comes in. So I felt it was an alternative housing system, but not necessarily one that people tended to really enjoy. So the idea is that it just shows, it just actually gives us an example of healthcare utilization in an older population and why people are seeing this as a major fiscal and demographic challenge moving forward. So of course, I'm telling you the mindset that I actually had as an intern. And then I came across this paper because this was a gentleman by the name of Walensky, a researcher from the United States, who actually was doing work as part of the American Longitudinal Study on Aging. And he simply asked the question, he followed a cohort of 7,500 older adults over a 7-year period, and they were all 70 and above. And he just said, well, how often are they living in the hospital, right? How often are they actually going going to hospital and spending their time in the hospital. So if any of you have seen this presentation, you can't answer, but everyone else, you must answer. Okay, so which piece of the pie do you think represents no hospital visits whatsoever over the 7-year period in this population of 7,500 older adults? Who thinks it's the 42.6%? We have 1 brave hand, okay? Who thinks it's, wow, if she's right, you're all going to be embarrassed. Who thinks it's 24.6%? Okay, we have a few more hands, about 5 or 6 hands. Who thinks it's 6.8%? Okay, we have the same 6 or 7 hands. Who thinks it's 4.8%? Okay, a few hands there. Well, this person here, absolutely correct. No hospital episodes, okay? And it just really reminds us that over that period, it's not to say that an older person will never go to hospital, but it reminds us that when you actually turn 65 in our society today, you actually have about 20 more years of life ahead of you. And actually the majority of those 20 years are actually going to be spent in relatively good health. So this population that I never really got exposed to, well, because they never came to hospital, this population, you think about active older adults who may be attending a lecture by the boring Dr. Sinha, or they might be traveling or taking care of grandchildren or remaining members of the workforce. So again, remembering that there's a large segment of the population, not to say they'll never go to the hospital, but are living for long periods into older age in relatively good health. The next piece of the pie was what Walensky deemed as consistently low users. So these are people who use the hospital once over the 7-year period. And this might have been to get that elective knee replacement so they could continue running after the grandchildren or hiking Kilimanjaro or whatever was their fancy. Or maybe they had a reason, a traumatic reason to take them to hospital. And that was the end of it. They got fixed and they went home. The rest of the pie that would add up to 100 accounted for people who used the hospital 2 or more times. And Walensky particularly focused on 2 small slivers. One was what he deemed was the inconsistently high users, and the smallest piece were what he called the consistently high users. So the consistently high users are those older adults that I would see routinely who have illnesses like congestive heart failure or chronic obstructive pulmonary disease that tends to have lots of exacerbations almost on a regular basis, and that would kind of have the hospital a bit of a revolving door for them, for example, when things got a bit out of control because they had an unstable health issue. The inconsistently high users were maybe those individuals as well, but maybe there were other things that also complicated things that made it a bit more unpredictable, like issues of mental health, or maybe dementia that actually has behavioral issues. Maybe there was a hip fracture that you threw in the middle of that mix as well. And so again, what Walensky was able to show at the end of the day was that actually only a small proportion of older adults are consistently extensive users of hospital services. So that was a really, really important piece to actually learn. So then Walensky said, okay, well, wait a minute, if we can conceive that there's a big group out there that are relatively healthy and doing their thing, then what really characterizes, what characterizes or defines that small sliver of older adults? And we kind of hinted at some of the issues in particular. Does anybody want to take a guess at what would define? There are 3 things in particular that he found that help define those older users.
Chronic condition,
Okay.
diabetes,
Yeah.
heart disease.
So polymorbidity, right? So perfect. So nicely aligned. Good answer, and right there. So having multiple chronic health issues. So these are older adults who tend to have 4 or 5 or more medical conditions. In fact, when you look at the Medicare spending data, so Medicare is a program in the U.S. that actually, takes care of virtually all the healthcare costs of those who are 65 and older. And in that population in particular, you'll find that 80% of the healthcare spending in Medicare is only on 20% of the Medicare population, the older population, who have 4 or more chronic conditions. So again, really showing, kind of that polymorbidity, multiple chronic issues are at play.
People who are completely isolated, alone, don't have support, family?
Absolutely. Yeah. So that's the 3rd point. Anybody want to guess the middle point?
Financial?
Not that one.
Depression.
But that could affect it.
And depression, some element of depression?
Not exactly. I put that more in polymorbidity.
Poor housing.
So that's an issue as well. But what we'll do is, we'll actually say that the second one was called functional impairments, right? So we think about functional impairments as, we have these things called our activities of daily living. So this is how a geriatrician will rate you based on your function with your ADLs, your activities of daily living. So the easiest way I teach my students to remember this are the 6 things you probably did in this order in this morning before you eventually got your way over here. So you went from a lying to a standing position, wherever you're sleeping, if it was in the bathtub or if it was in bed or wherever, you got from a lying to a standing position. That's called transferring yourself, transferring between different positions. You then walked over to the bathroom, you then toileted yourself, you then bathed yourself, you then dressed yourself, and then you ate something, right? Those are your 6 basic activities of daily living. And we know that these older adults in particular have problems with one or more of those activities. Maybe they have trouble walking or doing their transfer, so they need someone to help get them out of bed. Maybe someone help transferring, maybe someone to help dress, maybe someone to help with a bath, for example. So again, we're talking about having an impairment with one or more starts limiting your mobility and your ability to stay completely independent, for example. And the third aspect, when we're talking about transportation, when we're talking about poverty, is this concept of social frailty. And so the way I think about it is this way. We are less likely to be living nowadays compared to 50 years ago in an intergenerational household, right? Very rare now to see people having all generations live in the same house, which was very common in many other countries and not so uncommon years ago, for example. We're also less likely to be living in an intergenerational community. So we look at how much mobile we are as a society. This is a whole new concept that's rapidly happening in China, where you're actually seeing massive shifts of the population as people are entering the city, leaving mom and dad back, in the community that you came from, for example. And so, I always give the example of my parents. I have 2 aging parents in Winnipeg, and they had 2 sons, and one's in Toronto, me, and my brother's actually in Baltimore. So while we're connected on Skype and Facebook, and we're more socially connected in some ways more than ever before, if mom needs help getting the groceries, for example, I'm not going to be doing that, for example, right? So you have people who are less socially connected. People are less likely to be going to church, to synagogue, to mosque these days. So we to belong to social clubs. So we actually are more socially isolated than we are ever before. And so hence, if you don't have that support and you don't have that access to income, resources, good quality housing, transportation, all of those other things that are really those social determinants of health, then all of a sudden you can understand how that can start easily affecting your reasons to be bouncing in and out of hospital so often. So why should this matter? Well, when we actually look at the healthcare costs, going back to that issue, in Ontario alone, so ISIS, this Institute for Clinical Evaluative Sciences, they did a study to help me with some of my costing work this past year, and they basically said that amongst the 65 and older population in Ontario, so this is just the healthcare spending, which again, we have a $48 billion health budget, but $24 billion goes towards the care of older Ontarians. So you can actually see that the 10% of the most medically complex older adults in Ontario account for 60% of that $24 billion in spending, okay? So you can see that if we don't get it right for that population that's quite frail, has all of those issues, and now you know what those 3 big categories are, you can see how that's a huge cost, in our system. And as that population doubles over the next 20 years, again, it just means much more spending that we need to have down the road. But this is the other aspect. When we think about the least complex 50% of our older older adults in Ontario, that 50% of the least complex only account for 6% of the healthcare spending in that population. Right? So again, it reminds us again that there are a lot of people who are doing really well. And so one of the goals when you started thinking about what does a senior strategy look for in Ontario, even though the Minister of Health and Long-Term Care launched the strategy, she's a demographer and she is very big on social determinants of health. And so we both conspired basically to say, how do we make sure that 50% grows to 75%? And how do we take that 10% and lower that number one, or even make sure the 10% that are most complex, if we do things better for that population, then we can actually look, instead of having 60% of our costs, maybe we can actually bend that cost curve and change that differently. So this is why it's important, and this is why it really matters. So when we think about older adults as well, we have to remember that older adults are not the same as, it's not just that you slap on a different age, for example, and you have an older adult. There are things that happen as we age. And this is kind of the whole field that when I was trained to be a geriatrician, I had a whole course at Hopkins that I had to do on the biology of frailty, on, and understanding all of these different things that actually happen as we age and we grow older. So I'll just review some of the common categories, because I think it's important as we start thinking about what do we actually need to be thinking about as we grow older. So first of all, as we grow older, our vision changes naturally, right? So we see more and more older people who have glasses. But the lens of your eye, the lens actually in your eye, it actually starts to yellow as you get older. So things start to look a little bit more yellow than they did in the past. It's also not uncommon to start developing issues like cataracts, glaucoma, and other things that can happen with older age. So it's not uncommon to experience visual changes as we age. 25% of older adults also report that they have troubles with their hearing. And so just that's again, it's just a common phenomenon. So the thing is thinking about how it is to live in a world where you may have some visual impairments and you throw on some hearing impairments as well. It just means your ability to get around and to do things is a bit more complicated. Also, cognition, so our thinking, our memory, and so on, those things will change as we get older. And so it's not uncommon. Some of my patients say, "I'm having a senior's moment," for example. I forgot that word. We all have that at all ages, but it becomes a little bit more common as we grow older. It's a little bit our thinking sometimes becomes a bit slower in terms of calculations and processes. That's all natural as we get older and so on. However, if you start having issues with your memory or your cognition that start impairing with your ability to do things like your banking, to take your medications, to do that, that's not normal cognitive change. That's actually what we start calling a dementia, for example. And as we know, the rates of dementia actually increase as we grow older. So amongst the older population in general, it's about 13% of all older adults will have about 5 to 10% or so will actually have a dementia, for example. But we know as you get increasingly older, when you're 90 and above, for example, 37% of older adults will actually have a dementia. So this is why we're hearing a lot more about dementia, just because we have people living into longer cohorts. And we know that the number of people with dementia is going to double, mainly because the number of people living into older age is going to double. It's not that it's a disease that's spreading or is contagious. It just means that there are things that we need to consider as we go forward. The other thing is, how many people here have heard of osteoporosis? Yeah, so Osteoporosis Canada has done a really good job now, because everyone knows about osteoporosis. So how many of you are taking your calcium and vitamin D? Right, yeah, only a few people, right? So the key is that we actually know that 50% of older women, 25% of older men will actually have osteoporosis, brittle bones. Many more people will have osteopenia. And it mainly is the idea that as we age, our bone density and our muscle mass overall will decrease over age. So these actual things, your bone density, your muscle mass, they actually peak in your late 20s, your early 30s, for example. So you can imagine my 100-year-old patient, for example, is 70 years away from their actual peak bone mass and their peak muscle mass. So you can understand why osteopenia, osteoporosis become issues and why we have to think about those things. But also, how many people have heard of sarcopenia? Okay, so we have only a few hands. So think about it the same way. It's the same thing that happens to your bones that happens to your muscle. So you actually have decreased muscle mass over time. So think about it with, if you think about someone who's older that you know, or if you are older yourself in this room, say, are you as muscular as you were way back when? Are you as tall as you were way back when, for example? We know that we have decreased muscle and bone mass. And the point that I want to make for all of you is that I always like to say bone and muscle equal function, right? So the more bone and muscle you have, makes it easier to push things, to lift things, to do those sorts of things. So we can understand that as you get older, if you have less bone and muscle mass, you have less of what we call functional reserve. So you may need a certain amount of strength, if you will, to do an activity. And therefore you'll have a functional reserve on that point. So I'll give you an example to illustrate this. They took 20-year-old football. It's amazing what young people will actually do for some money, right? So they actually took these 20-year-old football players and they actually put them, they put them in bed for a week and they said, you guys can't move at all, okay? And after a week, they let them get out of bed and walk around and so on. And they basically lost 10% of their function, right? Because they lost muscle and bone and stuff. So they lost 10% of their overall strength. But they were able to still get around and walk around, just they were feeling more weak. For an older adult, we know that just one day of bed rest, you actually start seeing bone and muscle breakdown at a very rapid rate. 5% of functional loss on a daily basis with bed rest in an older adult. So you can imagine that if it's 5% a day in an older adult and 10% a week in a younger adult, and you already have less functional reserve to begin with, you can imagine why older people go into hospital, and if they're in bed for a prolonged period of time, you may start losing some of those functional capabilities that may reduce your ability to stay independent when you return home. So it's a big issue. And something we have to think about. But also when we start thinking about, an age-friendly city or these sorts of aspects, are we making sure that we have environments that older people who have less functional abilities can still get around, in particular?
Could you add balance issues to that list of?
It goes in the others, right? Absolutely. So balance is also something that becomes a bit more impaired as we grow older.
I saw a presentation, but I don't remember the author, of a book where people in nursing homes were doing exercises and really improved their functioning,
Absolutely.
even at the age of 90.
So I would say to my patients, move it or lose it, right? The idea is if we don't, but it's something we wouldn't naturally think about, right? Because it's not something, whenever you feel ill, what do? You feel tired, you feel weak, and what do? You went to bed. We're all conditioned to do it, and it's what we want to do. But we're actually learning that for older adults in our hospitals, actually bed rest isn't the best thing. That we actually, we don't want to not let people sleep, but at the same time, we want to make sure that people stay active, because there's some great studies that have been showing that older adults in hospitals are only actually standing or walking 43 minutes of every day. The rest of the time, 83% of the time, they're staying horizontal in bed. So you imagine that, and you can start seeing why people lose function. And then why we say at the end of the day, well, the pneumonia is treated, why can't you go home? And they're like, I can't walk. And you're like, why can't you walk? That doesn't make sense. And when we actually, contributed a little bit to that by not actually encouraging it. So there's a whole sea change that we have to start thinking about in terms of the way we interact with our environments and the way we actually think about older people engaging with their environments overall. So this is an example just on the visual one. This is what it's like, for a person looking at this picture with normal vision. Now this is what it's like if you're looking through the lens of someone who has cataract, for example. This is what it's like if you have age-related macular degeneration. And this is what it's like if you're looking through an eye of a person with glaucoma. So again, it's just one of those aspects where it's helpful to understand, because all of a sudden, if you now said, well, I've got 25% of the population that might be looking through the lenses of those latter three, for example, what am I going to do about signage? Right? Maybe actually having a bigger font that actually uses a lot of contrast would actually be a good thing, so that all eyes could see it. The normal eye, you could see that absolutely, but for that person with glaucoma, who is a very limited field, for example, or the age-related macular degeneration, where they sometimes have to look around, for example, you want to make things easier for that visual eye to actually see. You also see that contrast becomes something more difficult for an older eye or an eye with these issues to see. So how do you start thinking about it? So again, it's that idea about once we become more aware of these issues, one is we always want to treat issues where we can treat, but we should be looking at how do we accommodate those issues as well, for example. So the dilemma that we really have is the way in which our cities, our communities, and our healthcare systems are currently designed, resourced, and organized and delivered often tends to disadvantage older adults with chronic health issues in particular. And this has been known for a long, long time. So this is one of my patients. This is Mr. W. He doesn't live too far away from here. Does anybody want to guess how old he is?
104.
104.
85.
85?
101.
101? So he's actually going to have his 103-year-old birthday next week. Okay? 103.
Oh.
Sorry. Yeah, no, exactly. I'd be a miracle man if I could 130. He's not intent to staying alive till he's 130. But if anybody wants to think about Mr. W's cognitive capabilities, his thinking capabilities, you just look over the windowsill and you see those Rubik's Cubes. We joke about those all the time because I'm like, I can only make them look like that if I don't touch them. Or I should change all the stickers, basically. But he can do them, right? But, you know, Mr. W is one of these fiercely independent older adults who is just determined to stay in his one-bedroom apartment at home. He lives alone. It is only until about 10, 15 years ago when his one of his sons actually moved to Toronto, so it was kind of close by. But his son kind of visits him every 2 or 3 weeks, so it's not like Mr. W can rely on him every day. He's frail. You know, he needs a walker to get around his apartment, but he has the support of community care workers who come in to do some to help him in the morning and help him in the evening, just to kind of get his things. He's a very charming man, which is actually a very key thing if you want to know how to live a long life. You know, it's actually being very charming and extroverted as well. So he actually acquired his girlfriend, Jean, who's 30 years his junior, and he's just a lovely man to be around. But Mr. W is one, you know, who again, you know, he struggles with these issues of aging, but he wants to stay independent and he wants to stay at home. And so how do we think about them? So he became quite tickled because I said, you are going to be the poster child for the senior strategy. And he said, I've always wanted to be a poster boy, even at I was 3. So he gets a real kick, actually. And he recently actually required hospitalization. He's a guy who has about 1 million different medical issues, and he's quite frail. But we've been able to keep him out of hospital at home for quite a long time because he has a family doctor who comes visits him at home. But he was recently in hospital, and when I thought, well, how is everybody going to understand who he is and what he's all about? So I had one of the pictures of Mr. W. So we printed it out and we stuck it in his room, and it's one of the pictures at the end. And everyone was like, okay, we know what we need to do to get him back home immediately because he's not a 100-year-old demented gentleman who's going to go to long-term care. He's a person who wants to go home, and he's actively living a good independent life at home. So Ontario's long-term care, so Mr. W doesn't want to go to long-term care. You know, he says, I want to stay at home for as long as possible. And right now we know that there's 78,000 long-term care beds in Ontario, and the need, if we don't do anything differently, if we just think about population aging, we're going to need to triple the number of long-term care beds we actually currently have in the province. And, you know, and to build a long-term care bed, again, who pays for long-term care beds? We all do. It's taxpayer dollars. It's $150,000 to build a bed, and it's $47,000 a year for the care envelope that we pay for as tax dollars for everybody in a long-term care residence. And so the key is, you know, long-term care is an incredibly vital sector, and we need it to be there for people who need that 24-hour clinical support and care. But the key is, at the end, is you can start seeing why we know that meeting the needs of an aging population will cost more, especially if we don't do anything differently in particular. But this is the challenge. We also know that, for example, when I first met Mr. W 2.5 years ago, when he was hospitalized, you know, he was one that over a weekend, he had suffered some functional decline because he wanted to stay in bed, and the nurses said, well, let's just not disturb him, let's let him stay in bed. Well, he went from walking with a walker to being a 2-person assist within 2 days, where he needed a person, and by the end of the weekend, 2 people to lift him up, to get him out of bed, basically, to go to the washroom. So you can tell, functional reserve. He lost a lot of function very, very quickly when he was bedridden, for example. And so by the end of that weekend, you know, in his chart, it kept on saying 100-year-old demented gentleman, you know, probably going to long-term care, etc. And so when I first met him on Monday morning, I could tell he wasn't a demented gentleman. And he told me he wants to go home. So I said, well, you know, you gotta move it or lose it then, right? If, you know, we're gonna get that catheter out and you're gonna walk to the bathroom. He's like, well, I need help. And I'm like, we'll get you help, etc., etc. And we had him home within 2 weeks after that. But the key is that we know 37% of Ontarians who get designated as alternate level of care for long-term care right now are ones who could return to their own homes with home and community support. So are we actually providing that that mechanism, right? So then the other aspect is that when we think about Denmark is a country that actually avoided building any new long-term care beds when they were exactly in our situation back in 1980. they actually started investing more heavily into home and community care. And by investing more in home and community care, they were able to avoid building any new long-term care beds over 2 decades by strategically investing in its home and community care services. So again, some lessons learned. And they actually were able to close a number of hospital beds as well, because people just weren't needing them anymore because they were staying healthy in the community. So this brings us to why we developed, or why there was a call for developing a provincial strategy. So we have a huge fiscal and a demographic challenge. And so our Minister for Health, back in January of last year, she decided we needed an action plan for healthcare that was based on principles of equity, access, quality, value, choice. And the key thing is in Ontario, we have Cancer Care Ontario, we have a cancer strategy, we have a diabetes strategy. I always joke with, I joke with the minister when I first met her back, before this, saying, we've got a strategy for everything, but it's kind of like we're doing all that, but we're not hitting the actual issue here. That, when we think about healthcare utilization and who owns the cancer, who owns the diabetes, who owns it, it's actually the older Ontarians who own it. And are we actually thinking in a more holistic way around their needs? And then how do we deal with the other issues as well? So she liked the idea and decided to develop a senior strategy, and highlighting it as a way that we could work as a province to develop some best practices and policies at a provincial level that could support that delivery of health and social care services with an intense focus on supporting older Ontarians to stay healthy and to stay at home longer. So I got appointed in this role in May of last year, and she said, I hope you like to travel, because she said, you're going to every part of the province, because she said, we're not doing a consultation unless we make sure that every Ontarian can have their opportunity to have their say. So I had a team with me from the ministry, and we were able to, I was told to dampen my expectations that when we created a survey for older Ontarians to respond to, I was told that I'm working on the City of Toronto Senior Strategy as well, and that one they had about 400 responses, and I was told, well, provincial, maybe you'll get like, maybe you'll get about 500-600, because people don't really pay attention to these issues and they don't really care, and it's the summer as well, so calm down. 5,000, right? I remember my team was, going crazy because it was like, more and more keep coming in, but they loved it because we went through every single response that we received. We also did town halls and engagements. We worked with 2,500 health, social care, and community care providers, municipal officials too, lots of mayors participating, other civic officials as well, and we got to 1,000 caregivers as well, because one of my biggest concerns was caregivers are so busy caregiving that they don't really have time to go and participate in some consultation process. So we did 800 telephone surveys, 45 minutes in depth, where we asked the caregivers in depth what were their issues in terms of caring for loved ones who are older adults, for example. And then the Ontario Caregiver Coalition also did their own survey as well of about 300 caregivers, and we were able to get a lot of valuable information. We also work with stakeholder groups from across the province, groups at a provincial, a national, a regional, and also an international level. And again, presented their ideas, we dialogued with them, and we really were able to kind of say, we really want to get as much information here, because I kept on saying, this is not my report, I can't do this on my own. So it was really lovely to see how many ideas and how much support, and actually how much consensus there were on the basic things we needed to do. And so all of that together culminated in the document that we called Living Longer, Living Well. It was my report that I presented to the minister on December 20th. And we launched the report on January 8th, and actually it was so massive they never received a report that large, that they just finished the translating, they're doing the typesetting right now, and so the full document, the 200 pages, the 166 recommendations, will be out shortly for public consumption and viewing as well. So these were some of the things that I realized, over the summer about barriers in terms of integrating care for older adults in Ontario. It was, first of all, we do little to empower patients and caregivers. So despite there actually being resources and services everywhere, as I started learning, often, our patients, their families and caregivers are often telling us that they're not sure how to connect with them and how to understand them. So, again, one of the themes that I kept on hearing was, can we have user-friendly and comprehensive 24/7 single points of access to information? So, for example, we have a system in Ontario called 211. It's just by last year, it's now in every part of the province. It's available in 150 languages of choice. And again, you can call it up, or they're now going to make a web interface as well, where you can actually learn about services and connect better. But again, it's making sure that we empower older Ontarians and caregivers and family members in terms of getting access to information. It's almost like we're in a sea of resources, but people don't know how to touch them, basically. Next thing was, the other realization was we don't know what we don't know. So this is the fascinating thing, that no health, social, or community care providers in Ontario, other than geriatricians per se, are actually required to learn about caring for the elderly. Well, I thought it was just doctors, because no medical school in Ontario actually formally does geriatric training. Every med school in Ontario has pediatric training, and that's really good, because only 14% of the population are children. Yet, nobody who's the rest of the physicians who will be taking care of older adults don't have any formal training in geriatrics. So I was beating myself up as a physician and the OMA on this one. And then the ONA came forward, and the Ontario Nursing Association said, oh, we're no better. And then the Ontario Association of Social Workers said, and neither are we. So it's the whole idea is, it's a bit concerning when we actually are not training people to actually learn about the people they're actually going to be caring for and making sure they have the skill sets to do better. And most of the professionals, weren't thrilled about this either. They said, well, of course it's hard for me to take care of this older adult. Maybe I'm not getting those transition rates because I don't actually know, what I'm supposed to be doing in terms of caring for that older person. We also don't talk to each other well. So health, social, and community care providers are doing a lot of great work, but they're not required or even encouraged to talk to each other about their care, their common patients as well. So we have a lot of primary care providers who say, we have these community care workers who are doing these things and providing services, but they never tell me what they're up to, and it's really hard for me to find out what's going on, and vice versa. So how do we actually start making sure that everyone's actually talking to each other and actually sharing information as well? Because that's so important, especially when an older Ontarian who may be one of those have more complicated issues, may be touching so many different parts of the system that they really are counting on us to talk to each other and do things well. We also as a system plan in silos and not as a system, for example. Hospitals have their own budgets, long-term care facilities have their own budgets. There are all these different organizations. There's actually in Toronto Central this region of 100 and which is over 1 million people, we have about 237 different health and social care provider organizations. It's a bit ridiculous, right? When you actually think about we have this many different groups. And the key is that they all have their own executive directors, their own strategic plans, their mandates, and is it all actually working together as one system or a little bit more of a silo? So how do we actually start making common and relevant accountability frameworks, metrics that start promoting system performance across all our levels of our healthcare system? And then the final piece is, the final issue I found was we plan for today and we don't plan for tomorrow. So right now, for example, in Ontario, I go into the Ministry of Health, they have a really, really scientifically derived system to actually say that, okay, we just need to build more long-term care beds, here's the 150K, this is the care envelope, this is exactly how you do it. But when we talk about home care planning and understanding what the home care needs of the local population, when we think about supportive housing, less intensive care environments, for example, we have no system to actually do any capacity planning. And then thinking about how do we think about all of that together. So again, we really need to develop more robust capacity planning frameworks that start looking at that right mix of care that needs to be in a community, and often a mix of care that sometimes is even cheaper and is actually more in line with what people actually want. So these were the key strategic themes and areas of focus, really, that we got. These are actually the chapter titles for the report. And you can see that very quickly, it wasn't just a report about healthcare. It wasn't just one that was looking at what we do about primary care, community care, long-term care. But the lead chapter is all about how do we create elder-friendly communities? How do we promote health and wellness? Because people said, just tell me how I need to stay healthy and stay at home longer. What do we do for our caregivers? What do we do about ageism and elder abuse, which are still very commonplace in our society? How do we meet the needs of special populations and special needs of older adults? So for example, when we start thinking about mental health issues, when we start thinking about palliative issues, when we think about specialized populations like our LGBTQ seniors or our Aboriginal seniors as well, how do we start thinking about their unique needs and better meeting those needs? And then what are those enablers? What are the governance frameworks? What are the ways in which we actually get these recommendations actually implemented? So that's kind of the whole basis of what the report was looking at. But mainly thinking about promoting health and wellness, also thinking about how do we deliver better care, but also thinking more broadly than just healthcare. really getting into things like poverty reduction, housing, transportation, and thinking of those social determinants of health. So I'm just going to spend a few slides talking about this concept of elder-friendly communities, and then we can actually break for questions as well. This is Mr. W. at his 3-month review of his medications, and you can see he keeps them all in a cookie tin in the kitchen, right? And Jean actually fills out the dosettes for him, and there we are negotiating a few of the pills because we had some differing opinions, but we're better for it now. Again, so working in partnership. So what defines an elder-friendly community? I love this definition. I get shivers every time I read it because it really is one that the World Health Organization came up with in terms of thinking about a community that recognizes the great diversity amongst older persons. It promotes their inclusion and contributions in all areas of community life. It respects their decisions and lifestyle choices. It anticipates and responds flexibly to aging-related needs and their preferences as well. I'm thinking, who wouldn't want to live in that community? And even, you don't even have to think about older persons. We could just take out older and just put persons, and that would just be a very exciting community, I think, for any of us to want to aspire to live in, basically. So the elements of an elder-friendly community are really, these are the WHO framework that they've adopted. But again, Ontario, we're actually working on the City of Toronto Senior Strategy right now, and we've adopted this framework as well to be thinking about, and many communities in Ontario are working along this framework as well. So just a few concepts. The one about respect and social inclusion. So we're making sure our public services and our media and our faith communities are respectful of the diversity of needs amongst older persons and willing to accommodate. So are we making sure media is presented in formats that actually make sense and that allow people to communicate? When I was traveling around the province, I had some faith groups that told me how they saw a drop-off in the number of older adults coming to their services, and they realized that things weren't actually mobily accessible, so people just didn't even want to bother to come. So when they built their new place of worship, for example, they made it one level, or they made the prayer hall on the main level, for example, and that allowed people to not feel, that it was going to be too much of a burden, because they didn't know if other people would care to actually help them up the stairs and so on. So it's just thinking about how do we keep things inclusive in the way we do things in very simple ways. Social participation, are we making sure that elders have opportunities to allow for the development and maintenance of social networks within their communities and neighborhoods? So thinking about things like elderly person centers, it's a program they have in Ontario of just basically senior centers. And the government actually, with the health ministry, actually funds in partnerships with municipalities 272 of these centers. And you remember, and 250,000 older Ontarians actually engage and hang out at these places. And you know what? What I found, I was like, oh my God, 272 of them? That's double the number of hospitals that we have. And we have a $48 billion budget. How much money are we spending on this program? And you know how much money we're spending? $48 billion budget for the healthcare? $11.5 million. So little, but these centers, when I go visit them, people are having a great time there. Centers where you can meet other people, you can participate in activities that are meaningful to you, because the older adults who participate are the ones who actually drive a lot of the programming. And it's great to see an opportunity for people to re-engage and make new friends, especially when some of your spouse, you may have lost your spouse, you may be losing friends, and this is a great way to form new friendships as well. So are we making sure that the older people have opportunities to participate in community decision-making, employment, and volunteerism activities that cater to their abilities and interests as well? So it's only recently that we ended mandatory retirement in Ontario and in the country, and we actually have twice as many older people now, or twice the percentage of older people actually working into retirement than we ever have before. So again, it's giving people the right to actually choose to work if they want to, or participate, in making sure that we have ways to engage them. And then thinking about our outdoor spaces and buildings. So can older persons get around easily and safely in the community as well? Are we making sure that our spaces are publicly accessible? So I actually just sent, working with the City of Toronto, when they saw this slide from me, I obviously got some interest piqued, because I always show this slide and say, why does Mr. W like this park bench?
You get in and out of it.
Yeah, exactly. He's got the arms, you can get in and out of it, right? So I saw these, and the reason I started putting this one up was because I saw some of the new street furniture that was going up, and I'm like, who was that meant for? Because I don't know who that was exactly meant for. So it was great because we've now stirred a lot of interest in this. And so I actually worked with the team from with Toronto Rehab Institute. We actually sent in a briefing note for the city managers to think about redesign of our park benches in the city to, again, to be more elder friendly and to be more accessible. But I was at a city planning meeting the other day, and I showed this slide as well. And then one of the persons said, well, forget the elderly. Pregnant ladies, this would be great for them too, et cetera, et cetera, et cetera, right? So again, it's just about the idea of promoting accessibility, and because that, makes a difference. So people say, well, how would I want to go to the park and sit on a bench? I might not be able to get up, right? So again, it's just thinking about those opportunities and reducing those barriers as well. So we heard about housing here. Do older persons have homes that are safe, affordable, and conveniently located while promoting independence as their functional needs change? And do we make sure that people actually have transportation options so they can travel safely where they want to go in the community safely and in an accessible and affordable way? Because we know that older adults in general often outlive their decision to stop driving by about 10 years. So when people stop driving, the question is, how do you get around them? Especially if you're living in Mississauga and you want to get to downtown Toronto. I mean, do we have accessible is it affordable transportation? Especially when you may have certain things you need to get out and do, for example, as well. This is just a picture of Barbara, one of our house calls patients, and Leslie, who's the occupational therapist on the house calls team. And this was the inaugural day where we actually fixed Barbara's wheelchair lift so she could get in and out of her house. And I joke quite a bit with my patients, but the family car is just the one over on the right there. And so I always do this. So I do this thing with Barbara. I'm like, Barbara, those old commercials where they'd actually show, you just won the Super Bowl. Where are you going to go? And they're like, I'm going to Disney World. So I'm like, Barbara, your stair lift is about to be inaugurated, and we're gonna go up and down on it. Where do you want to go? She's like, Dollarama, right? And she has a really good Dollarama around the corner. So totally understood, right? But the key thing is, again, it was about her having her independence back, to be able to get out of her home and to be able to engage with in the community again. So again, housing options vary considerably around municipalities, and are we allowing people to age in the place of one's choice? So you can age in private dwellings, your own home, retirement homes, supportive housing or assisted living environments, long-term care homes as well. But again, we need to have programs that are supporting aging in place. So there are programs like the Ontario Renovates programs. This is actually a presentation I gave. Part of these slides are from one I gave to the municipalities. But I showed that there was a program called Ontario Renovates where people could actually renovate their own home, for example, to actually allow them to stay independent in their homes. But when this program was downloaded to municipalities, 13 of the 52 decided to stop running the Ontario Renovates programs instead of other housing programs. So I met with caregivers this year who said, because I couldn't get the stair lift put into my house now, my husband with Parkinson's, he actually had to go into a long-term care facility. And again, that was a $4,000 stair lift, which could have kept him at home longer. But now we're all paying $47,000 a year to care for Mr. Jones in a long-term care facility. Again, it's all our own decisions. These are our options and choices of how we actually want to run things and move them forward. So I've been arguing with municipalities that we should all be doing the same thing together so that we don't have what we call a postcode lottery, if you will. So based on where you live. There are also actually property tax deferral programs, and actually in municipalities across Ontario actually have tax deferral programs so that if you're an older adult, you can actually not pay the increase in taxes and defer them and not pay the interest as well. And by doing that, and it's a program specifically for low-income older Ontarians, you can actually then say, I'm going to defer those taxes. I have a little bit more money in my pocket now to do things I can stay at home with. And by doing that program, and then when you sell your house, when you leave your house, for example, at the end, you then you pay the money back at that point, for example. So again, different interesting ways. But I remember going around the province. I was doing something with the mayor of Burlington in his community. And there were people that said, we never heard about this program. It's like, oh, we offer this program. So it was, again, an opportunity to say, there's a lot of stuff out there, but how do we connect people with that information? Also thinking about transportation options for older adults. Again, they vary considerably between municipalities. But older adults, as we talked about, outlive their decisions to stop driving by more than a decade. And programs that supporting transportation needs, again, subsidized transit programs. They have a transit ambassador program in Grand River and Kitchener-Waterloo, where again, if you're an older person, you want to learn actually just how to do it, like how to get on the bus. I had friends who are teaching now at U of T, and they're in their 30s, and they basically came and they were really scared about getting on the streetcar. They just didn't know how to do it. So I remember I actually became an informal transit ambassador. I actually showed them, here's the token, this is what you do, and now next time I called them, I said, oh, do you want me to come by and pick you up in the car? And they're like, oh no, we're going to get this streetcar, that streetcar, and everything. But I actually broke that opportunity for them to actually figure out how to use the big scary streetcar in Toronto, for example. So again, but it's a great program that they do. And again, there are many not-for-profit seniors transportation services through our community support service agencies, but how do we get and strengthen these to work in different ones? So in Toronto, there's the Toronto Ride Program organized by Sprint, which gives people access to subsidized rides and programs as well. So this is an interesting program in the U.S. called the Independent Transportation Network, and they developed a not-for-profit, dignified, consumer-oriented transportation system. It's available in 25 U.S. cities now, and it's available 24/7 a day. And it's kind of like a taxi service, but you kind of plan in advance. And the further out you book your car, and they have a volunteer driver, etc., the cheaper the price overall. But again, it's available for any type of ride, and there are multiple innovative ways to self-finance rides. So older adults might actually give the program their old car, for example, and then they get 100 rides for free or 1,000 rides for free. Or there may be younger people who have a car, will drive around other people, and then they actually build up credits that they can actually use themselves, or they can give to someone else. Or if you're a guilty son in another province, for example, you could just write a check and buy mom or dad with a whole bunch of rides as well. So really innovative models, and I've actually been talking to the founder of the program and saying, could we actually bring ITN to Canada? Again, as a way that we could strengthen our community support service agencies in developing these things as well. So the last few things are thinking about communication and information. Are we making sure that we're communicating in accessible ways? And for community health support, do older persons have access to social and health services they need to stay healthy and independent? So I was on the radio this morning talking about community paramedicine because people heard about that very unfortunate story about that older woman who unfortunately, because the paramedics were so busy doing a whole bunch of different call-outs, that unfortunately what appears to be the situation was it took 3 hours to get an ambulance to her retirement home, and she had unfortunately passed away by that point, and so on. So again, and this is the issue when you look at the data here in Toronto, and I work closely with the Toronto Paramedic Service here. The actual volume of calls that the paramedic service in Toronto has been receiving over the last 7 years has actually increased by 35%, but the actual number of paramedics has actually increased by about 2%, right? So again, when you have less people to respond to, or when you have only so many people to respond for increasing number of calls, you can see kind of what started happening in that situation where things that were deemed as more priorities kept on getting in the way of this lady getting the care she needed in a timely fashion. So again, how do is there a different role for paramedics? And that was the conversation this morning on CBC. Was are there things we can do differently to meet the needs of an aging population? So we know that older adults use 60% of our ambulance services, for example, and the majority of 911 calls are actually not time-sensitive nor immediately life-threatening. And I use the term lift assist, for example, because I actually found when I started working with the paramedic services here and in other jurisdictions, they were saying that one of the most common calls they have are when an older adult falls at home. And they may be home alone, and someone needs to come and help them get up again. And so it's often the paramedics who are doing this as well. So the paramedics say, well, wait a minute, well, this person's falling all the time. Maybe we could actually go in and help, rearrange furniture, do some other things to actually help them, not fall as often, for example. So paramedics often see individuals in pre-crisis situations and situations that don't require people going to the hospital. But we often just say your only duty is to transfer people, from home to hospital. It's not to do these other things. But they're a very highly trained and regulated workforce, and maybe they have a role to play in doing things other than emergency response or transfer. So there's this concept called community paramedicine, which is actually starting to grow, and Toronto's actually one of the leading areas for this in the country. So thinking of paramedics in non-traditional roles. And evidence is showing that it can actually reduce meaningfully 911 demands in paramedic services and thus reduce ED visits as well. And so in Ottawa, Niagara, Toronto, Renfrew County are where they're starting to develop some better patient system outcomes by using paramedics in more creative ways in particular. This is Chief Rastus's slide that he allowed me to steal because he steals my slides too. So, but again, it shows the idea that how can community paramedicine work as part of an integrated healthcare system to better support people. So one of the programs here is the top one called Community Referrals by EMS or CREMS, which is about connecting people to supports. And this is the idea that what they did was in 2011, they identified 904 older adults who they thought would benefit from a community referral, connecting them to Community Support Service Agency or CCAC. And by doing that, by simply picking up the phone and making a referral, letting the community care group know, they actually dropped the number of calls by 50%. They dropped the number of ED transports in this population by 65%. And the actual time they spent working with those older adults actually dropped by about 60%, because there weren't as many calls and there weren't as many trips to the emergency departments as well. So again, thinking about the opportunities that you see with community paramedicine, and this actually helped them save money that they could reinvest elsewhere. So they've been doing a lot of creative things, but again, this is something that the paramedic chiefs are saying, we want to do more of this, but again, we have to convince the government that this is something that they need to support as well, and we can do ourselves, because this is a very simple thing that doesn't cost any money to do, picking up the phone and calling the CCAC. But you can see if we make this a standard of practice, we can make our services that much more efficient and that less costly overall as well. And then when we think about the public health needs of our area, again, public health units are linked to municipalities, not with our regional health authorities. And their only major thing they do with older adults is around falls prevention. But are there other things they can do? Such as, for example, our influenza vaccination rates are lower than they were 10 years ago, for example, at 69%. Pneumonia and tetanus vaccination rates are incredibly low. So how do we actually start promoting those sorts of things too on a population health basis? So when the minister asked me, she said, can you just give me one slide that shows what the overall vision could look like? And so there was the Excellent Care for All Act that she helped pass. So I said, well, I'm going to call this the Excellent Care for All Seniors. And this is what it looks like when you start thinking about getting us thinking of care as a system and thinking about these different ideas of promoting wellness, supporting aging in place, thinking about care environments that are senior-friendly, elder-friendly, and making sure that we have enhanced long-term care environments. So the timeline for my work is that the action plan was launched on January 30th. I was appointed to lead this project starting in May 24. I handed my report in by the last day of fall, which is my joke, December 20th. And now we're starting to work in partnership with the minister and the ministry in terms of starting to implementing some of the recommendations that we can start moving on going forward. So this is my last slide, and this is Mr. W. When he heard that I got permission from the minister to leak the announcement to Mr. W, because I always joke that with Mr. W that every day is a gift at 103. And so I went and I told him, I called him on the phone and said, I'm going to meet you. And he's like, hey, so what's going on with you? And I said, well, I got this new thing. I'm going to be doing the senior service, so I might not be able to visit as often for the next few months. So he actually decided that before I came over to his place, he actually went on the internet because he learned how to start surfing when he was 93. And he decided that he was going to try and find me a report that I could just simply copy. But then when I went and saw him, he's like, I couldn't find a good report for you to copy. He said, you got your work cut out for you. And he said, now I understand why I'm 103 and there still is no senior strategy, or there will be one soon. But he's very thoughtful with his comments, and he actually said to me, Samir, I think this is Ontario's time to lead. And I think that it's a really good opportunity because the minister's very excited now because she's getting all the other health ministers and ministers for seniors across the country together on March 15th. And she's like, we're doing a tag team show to teach everyone else what we're doing, to start building some national support so we can start getting some national policies going forward. So I think there's a real opportunity for us to lead and learn from others and share what we learn with others as well. So thank you very much. So please go ahead, yeah.
It's so impressive what you're doing and how broad in scope it is and specific at the same time. Along your points regarding the future and individual empowerment, and your last point about Mr. W going online, I'm wondering what you're thinking about online resources for older adults, and if there's a component of your report that addresses that, or what research you think needs to be done along those lines.
Yeah, so I mean, it's really interesting. I mean, when we think about, again, information systems, people say just put everything on the web, right? Just put it on the web, that'll be perfect for everybody, because more older adults. So I actually had a group of older adults in Chatham who came up to me and they said, because someone was going on about, it all has to be, they were developing this website and said it's all about the website. And this group of older adults came up to me in Chatham and said, Dr. Sinha, don't listen to those people. Let me tell you, give us a phone line, for example, because you know what, first of all, they said, a few of us are actually illiterate. I'm like, what? Why are you illiterate? And they said, well, some of us grew up on the farm, and they said, who's illiterate? Are you talking about new immigrants, who come here from a place and they don't know how to speak or read English and stuff? And they said, no, a lot of them look like us, kind of grew up on the farm and didn't really need to actually learn to be very literate overall. We led very productive lives and everything, but literacy isn't our greatest strength. So if you make everything printed materials, if you make everything on the internet, we're not going to be able to access that. So certainly have things online as well, but make the main point, or if this is what you can influence, make sure that we have a phone line in language of choice. And so that's why I looked at resources like 211 as a way that people could access that. And obviously, and the other thing I learned is that, how we reward, people who, the people who have the most money, for example, go to banks and they don't go to the teller or the machine. They get, they get lattes and they get to speak to a personal banker. Or when I fly now, because I fly so much, for example, I get rewarded with a card that makes me stand in a line that gets me to a human being that much more quicker. So it's the whole idea that in our concept in our society, we reward, people with human contact. So again, it starts to think about that human contact sometimes is really, really important for an older adult, especially if it's hard to make sense, heads or tails of what this document says. So I think it really reminded me throughout this part that for many people, they want to be able to talk to someone, to be able to problem solve with someone, but also have the independence to look through information on their own, but then be able to talk to someone if they need that help.
An issue which may or may not be relevant specifically to this that came to mind is safety. In seniors housing, when I was working in home care as a social worker, I found clients who were living alone in regular buildings or senior buildings, mostly in buildings where there was also other ages, where they were scared because people would come to their door asking for money for drugs. And just thought I'd mention that.
No,
it's not even a question, it's just a comment,
no,
because it could lead to someone ending up having to go into a home or something because they're so afraid.
Absolutely.
Or it affects how they're functioning.
Yeah, and I think this is, it's something I'm very familiar with actually, especially in Baltimore. This was an issue in kind of city housing as well, because again, it's the idea that there were these schools of thought that actually started leading to more integrated housing, right? Saying that actually having seniors buildings is actually ghettoizing older adults, right? Because you're keeping them so that actually to have a more socially just society, for example, we shouldn't ghettoize older adults. We should integrate them with all ages in social housing. And I agree on many points to have intergenerational communities. But sometimes subsidized housing or social housing, for example, can bring people with different issues and needs together. And unfortunately, what was happening in many parts of some of the old seniors buildings in Baltimore that now had younger people in them, you actually had that exact situation happening. It happens here in Toronto as well, and so again, it's the idea of balancing a little bit of sometimes I can say whatever I want. Send me an email if you really think I offended you and so on. But there are a lot of older Ontarians who said, what, sometimes it's actually give us the choice or give us the opportunity to to sometimes live in a community where we feel safe and comfortable. And sometimes, this whole need to say, no, we can't have any age restrictions or whatever, it sometimes has done a little bit more harm than good. So again, sometimes, they have a term positive discrimination, for example, to allow people to live in buildings that are more oriented towards their needs of the communities. But really, it's more about giving people a choice about where they want to live, or giving people more choice and options about how to stay healthy and independent in the community.
Those of us who are older here have been through many of these suggestions by the Ontario government, regardless of who has been in power.
Yeah.
And they get dropped. What guarantee do we have this is not going to be dropped? That we really are going to implement the changes that you're recommending, like training. My mother was 97. She died 4 years ago, spending 11 weeks in an ALC bed. And I used to go in and say, I'd like to bring my mother's clothes in. Oh, we don't have time to dress her. I said, she can dress herself. Oh, then everybody want to get dressed. I said, you have a room at the end of the hall, 4-bedroom, full of equipment that nobody uses. Why don't you turn it into a multi-purpose room? Oh, we couldn't do that. We don't have staff.
Yeah.
These are people working with elderly people in ALC beds.
Yeah.
This doesn't make sense.
Absolutely.
You're right, training is important. But if it's not implemented, nothing's going to change.
I agree.
This is what scares me. I started a business in 1981 called Complete Geriatric Care, renamed it in 2008. It's called Iris Consulting for Seniors. You and I have exchanged cards.
Mm-hmm.
When I was 41, I said, my goodness, I hope things are better for me when I'm 65.
Mhm.
I'm 73, they're worse.
Mm-hmm. So I mean, and this is a challenge, right? I mean, this is the worst for anybody who's actually asked to write a report, right? Is it just gonna be Jeffrey Simpson and I have cooperated on a few things, and he left. I remember his biggest fear was when he released his book that it would become an instant rare classic, right? And I think and so I steal his line saying the last thing you want your report to be is go on the shelf with all the other expert lead reports and nothing comes about it. So I certainly negotiated with the minister. When I wouldn't have actually worked with her to do this work unless I actually believed that there was political will behind this as opposed to window dressing.
The same government started a strategy, saying aging at home strategy, and it was dropped.
Well, technically, so I mean, the aging at home strategy, if you will. So a lot of the report talks to a lot of the aging at home strategy money because that money is still in the system, for example. And I'll give you a great example of aging at home at work, for example, right? It just wasn't publicized as well as it could have been, and it wasn't really articulated what it was doing. So I'll give you an example. Mississauga Halton, for example, out of the $1.1 billion, a year that's actually spent, they get about $60 million a year, for example, as their aging at home allocation based on population and other things. They took 2/3 of their money and they built 1,000 supportive housing units and so that people could stay in their own homes or in there. By actually doing that, they actually have the lowest number of long-term care beds per capita in the province. They also have the lowest demand for long-term care in the province. And that's what Aging at Home was about, right? The other program, Mr. W, is actually part of the House Calls program in Toronto, which cares for about 400 frail homebound seniors a year. That's
We
paid
need it
for
everywhere in Toronto, not just at Sprint.
Absolutely, and that's actually paid through the Aging at Home strategy money. So we haven't articulated it well, but the Aging at Home strategy never clearly articulated a whole strategy around seniors. So I completely agree. I would not have actually done this unless there was actually a plan here. And I said, that, the minister immediately, before I even questioned her on this, she said, I don't want this to become an instant rare classic. So not only are you going to be assigned to actually write a report and hand it in to me, but she said, you're not going away after that.
Good.
You're staying on to help implement. So I have a team of 10 people at the ministry. But I mean, part of it is, the challenge that I've had during this whole process was, I remember it was October 15th, I'm sitting at my desk writing a chapter on primary care, and then I get all these emails saying, oh, the premier's resigned. I'm like, whoa, what do you do now? Where's that in the expert lead handbook, right? And then all of a sudden I'm hearing, oh, we're going to have a new premier, and then what's going to be that? And is my minister actually going to still be around? And she is and stuff. And part of the reason she's staying around is she's like, I want to get this work done, and I want to make sure. She said this is one of her key 3 focuses for the upcoming year for the healthcare system is senior strategy, health links, it's bringing providers together, and health system funding reform. So I'm hoping, I've given 166 recommendations, not only to the Ministry of Health, but to all of government and so on. And my goal is to see as many of those things put in place. But I think, what really happens is, what's been really good is we've actually seen a lot of people unite behind the report, a lot of people unite behind this movement, and I think the more pressure we put on them, and painting out the fiscal realities, I think really makes people understand that we don't really have many choices to actually do nothing. So we need to move forward, and the goal of this report was to make this comprehensive as possible, so that regardless of whoever comes into power in 6 months' time, I'm a bit scared about options, frankly, but when those options come in, at least they're going to have some document in front of them that can start giving them guidance and make good ideas and thoughts move forward. So I'm in it for the long haul, and I'm hoping I have a few years before I hit 65, but I'm hoping we move forward.
The other problem is that when you say to LDCs, your staff need to be trained in dealing with geriatric, oh, we can't afford that, it's not in our budget.
So
That's another major issue.
Yeah, so you have to remember that already the minister's moved on 6 of my recommendations immediately, right? And one of the recommendations made 3 of the key ones for long-term care. Long-term care homes are telling me we don't have the right equipment, we need more money. So and quite a few $1 million was just released to long-term care homes to buy the equipment you need. $10 million is just invested in educating more people in long-term care homes around the needs of older adults with behaviors. So there's actually been about $30 to $40 million of investments that were announced because of this report into the long-term care sector, and then other announcements have been made around community support agencies as well. So we're getting some movement, and frankly, if only one recommendation is followed, I was told be happy about that. My goal is to try and get as many of the 166 done over the coming years.
I mean, the other point you just brought up was when you've got dementia care people, you've got mental health issues in long-term care settings, and physically frail clients, residents.
Absolutely.
So we mix them all together right now, and we have issues like happened with the Parkinson gentleman that was featured in the paper. Why don't we have more appropriate facilities to deal with the aging populations within each of these groups? Because that way, we could probably do more, and physically frail people could be kept out of long-term care facilities so that they could be deemed for people who actually needed them.
All in the report.
Great.
Other questions?
You've been quoting the fact that you've had some great consultations with the seniors themselves as you've been going around the province. In your implementation stages, do you have plans that you will include seniors in the consultations? We're going to try this new implementation. How is it going to work with seniors? So often we go to meetings and it's all the providers, it's not the seniors.
Yeah, no, and that's why I was very clear that I wanted to make sure we reached now. Again, it's we had a very short period of time to try and reach as many people, and that's why I partnered with CARP, for example. I partnered with many organizations, many grassroots organizations, got together, made submissions, and I said, tell anybody out there to kind of communicate, to support. I had people writing me handwritten letters, and I would go on radio and say, here's my personal email address. Mail it to me.
You communicated very well.
Yeah, but the cool thing was, and I appreciate that, because there's still people out there saying, I don't think you did enough goodness, I don't think you reached out to enough people. I'm like, really? You try this yourself, okay? But you can only do so much, right? But anyways, the point is, I felt pretty confident in terms of our abilities to reach people. But of course, the key thing is as we move forward, we were all waiting to see if our minister would actually remain the Minister of Health. Now she is the Minister of Health as of Monday. She's now said, okay, let's get to work. She's like, what were you guys all worried about, right? So now the key is, we now have to start coming up with that the rest of the implementation plan. And the goal will be, as we start thinking about changes, we will want to be consulting, and we want to consult broadly with the people who are going to be the end users of these services.
Maybe you need a sign to put up, where are the seniors? And have it at all of the offices where you're putting together organizations, because they tend to forget.
Oh yeah, well I don't, because believe me, my patients tell me every day. They keep me in check. So.
I'm just wondering about the strategy to rejuvenate home care in meeting some of these needs. Your number 2 on functional capacities in particular. We have the house calls program, very limited, and family health teams with a greater role in getting out into the community and looking at more functional issues. But the home care program has been established for 40 years, and it's gone through different cycles of focus. Right now it's very limited to acute care, But traditionally, it started with the chronic care program as well as an acute care program, and addressed exactly the needs that you've identified. And that was abolished very quietly, surreptitiously, really, without any public debate. Just we're now doing acute care in the home.
Yeah.
And many of these people who are so vulnerable were out without services. And because they're so vulnerable, they don't even know to ask. They're often discharged from hospital with acute stroke, for example, don't know what to ask for. There are no outpatient services to help them, and the home care services that are available are generally oriented to their acute care needs. I know of people who, I'm an occupational therapist, who have received referrals for, assess safety in bath. We have one visit. And in fact, the person's had a stroke, they're just out of hospital, they have multiple needs, maybe cognitive, perceptual difficulties, at great risk, and the home care coordinator says, we have one visit.
Yeah, so with that, so again, part of it is making sure that, why was that person, why when that person was being discharged, if they had multiple needs, for example, why weren't they properly assessed in hospital at discharge and said these are the types of services they need? Because, again, and realizing how strapped our community support service agencies, our CCACs are, we spend more on long-term care for 100,000 Ontarians a year than we do on, we spend about $2 billion more we spend about 800 million more a year caring for people in long-term care, 100,000 people in long-term care, yet we care for 1.1 million Ontarians with our home and community care budgets, right? So again, we have to recognize that we spend, if we actually reverse that budget, that's kind of what Denmark did by investing more in home and community care. We have more care available at home. Just so you know, one of the key pieces that I wanted to push through the report, and the minister's actually already she announced the day she released. She actually surprised me because I didn't know she would actually make announcements that day as well when we released the report. But she actually moved on the community support service agency recommendation I did, which was again is getting back to restoring that old chronic care model. So the idea of community support service agencies that provide Meals on Wheels and provide day programs and a whole bunch of other services. Some of these agencies actually also do provide personal support workers, for example. And so they actually have the regulation is being changed now so that CSS agencies, community support service agencies, about 650 across the province, can now actually start brokering home care services for those types of patients again themselves. So if they're also doing Meals on Wheels and everything, they might say, and we'll put an hour or two in of home care, more preventative home care, to help you do with homemaking and the other things as well. So again, it's the idea that that's a massive change right now, which is getting everybody a little bit excited and hot and bothered right now. Because again, there's a lot of money at stake here, right? There's a lot of power struggles about all this stuff. But this is about the right care in the right time and the right place. So have we got it all right immediately? No. Is this going to make a massive difference? Absolutely. And I'm hoping to help shepherd everybody through this one so we do it properly.
So just going back, that's great, and I'm really glad that it's moving forward, but just going back to your point about questioning why the hospitals would discharge these people, we know why they discharge them. They discharge them because they want them out of the hospital. And sometimes they go out with referrals to home care for certain services that are totally ignored because each individual CCAC has its own criteria based on their own pre-decided priorities. And so the referral can go out and it's never acted on.
Well, and that's, so again, things aren't, so I have a whole chat in this about how standardizing services, making sure that we have common things. Again, I can tell you that at my hospital, that's not how we do care. We don't do care that way. We'd be ashamed if we ever heard that care was ever being delivered that way. And I think the majority of places are not providing care in that way. But when care is being provided that way, that is unacceptable.
Well, it's when you get out of hospital, you have no more control over it.
That's
because
right.
Referrals
Yeah,
at CCAC.
but again, if some CCACs are doing that, and I can say, CCACs care for 600,000 people a year, right? So I think the majority of my patients who are getting CCAC services have been having relatively good experiences. But there are people, when things don't go well, we need to know about those, because it's unacceptable. Because I can tell you, every CEO here would find it unacceptable that a referral went to them and it wasn't responded to. So again, part of the metrics I put in to kind of monitor the system is about looking at referral times, making sure people are getting response times in an appropriate manner, so we can do that. So, there's a lot of work that needs to be done, clearly, and I think we agree.
If hospitals were more responsible for the care that people get when they leave, instead of CCACs, let's have hospital-based hubs. Then they're going to make very sure that when the person goes home, like this lady's talking about, that the people are going to have what they need set up in the home, so they're not going to be readmitted. That's what we need to do. Let's get rid of all these silo effects within the government.
And so I think, again, there's ways in which we can start thinking about how do we better integrate the system, right? So I think we're on the right track. Was there one last question? Because I know we're running out of time here. Oh, I just want people who haven't had a chance to ask a question.
My name is Rohit, and the question I have is, could you identify maybe 3 factors that the system in Denmark has used to help preserve independence for seniors? And if they are all based on taxpayers subsidizing this, or is it private, is it two-tiered, is it insurance-based?
So they have made an insurance-based, a social insurance-based healthcare system in Denmark. But I think it's really just I think the fundamental thing they did was they kind of got the mix right. So they actually just had much more heavy investment. So all future investments in healthcare that they started making were more heavily geared to home and community, and more specialized environments within the community as well, so that they have more kind of group home settings, for example, for patients with specific needs like dementia, for example. But by providing more intensive home and community care supports, they're able to just avoid having to build long-term care facilities because there's more care. They also have a pretty good primary care system as well, and again, more professionals working in the community. There are other specific aspects of kind of decentralization of services, and they've had mixed successes to a certain extent with that. They also pay their PSWs a whole lot more than we pay in Ontario, and especially when they're the lowest paid workers in Ontario. You kind of get what you pay for to a certain extent, right? And PSWs are some of the hardest working people in our society. And so we have to make sure that, if we're going to say we want care at home, we want good quality care at home, are we prepared to pay for it? Because again, if you want to get everything on the cheap, well then you're going to get cheap results and results that you don't like.
Thank you.
I think we are absolutely, I think we've just hit the time limit. So I want to thank, so my email is at the end there. If people want to email, you're more than welcome to. Although I am going to Cuba on Saturday with a very bad internet connection. So you'll get an out-of-office response. But thank you very much for your attention, and it was a real pleasure and honor to speak to you today.
Thank you.